Welcome back to our channel, where we decode complex critical care concepts to make you a better clinician. Today, we will see how to recognize shock as per latest PALS guidelines. Shock is a physiological state characterized by inadequate tissue perfusion to meet metabolic demand and tissue oxygenation. A child in shock can actually present with a normal, increased, or decreased systolic blood pressure. All types of shock ultimately result in impaired function of vital organs like the brain and the kidneys. To understand how to recognize shock, we first have to understand the pathophysiology. Tissue oxygenation depends on oxygen delivery, or DO2, which is given by cardiac output into oxygen content. Cardiac output is determined by your stroke volume and heart rate. Stroke volume is influenced by preload, cardiac contractility, and afterload. Oxygen content is determined primarily by hemoglobin concentration and oxygen saturation, SaO2, plus a tiny amount of dissolved oxygen, PaO2. When a child goes into shock, oxygen delivery drops. The tissues are starving, so they start extracting more oxygen from whatever blood does reach them. This leads to a drop in venous oxygen saturation, SCVO2. Eventually, the body is forced to switch to anaerobic metabolism, which generates lactic acid. This is why elevated lactate is a massive red flag in the ICU. Shock can occur due to inadequate blood volume or oxygen carrying capacity, as in hypovolemic shock, including hemorrhagic shock, or inappropriate distribution of blood volume and flow, as in distributive shock, impaired cardiac contractility, as in cardiogenic shock, or obstructed blood flow, as in obstructive shock. Initially, when the perfusion drops, the compensatory mechanisms kick in. To fix cardiac output, the heart rate spikes. Tachycardia is often your very first warning sign. To maintain blood pressure, the body increases systemic vascular resistance. It shunts blood away from the skin and intestines, thereby protecting the brain and heart. There is also increase in cardiac contractility and increased venous tone. Clinically, you see cold, pale, mottled skin, delayed capillary refill, weak peripheral pulses. As blood flow to the kidneys drops, you'll see oliguria. If brain perfusion suffers, you will see an altered mental status ranging from anxiety to lethargy or coma. This brings us to identifying shock by severity. In compensated shock, child is poorly perfused, but their fierce compensatory mechanisms are keeping their systolic blood pressure within a normal range. In hypotensive shock, the compensatory mechanisms have failed and blood pressure rapidly declines. This was previously called decompensated shock. Remember, a child can remain in compensated shock for hours. But once they progress to hypotensive shock, you may only have minutes before cardiopulmonary failure and cardiac arrest. Now that we know how to spot the severity, let's identify the four main types of shock. Hypovolemic is primarily fluid loss from gastroenteritis or hemorrhage. Cardiogenic is a pump failure issue, like congenital heart disease or myocarditis. Distributive involves abnormal vascular tone, seen in sepsis or anaphylaxis. Finally, obstructive shock involves a physical block to blood flow, like a tension pneumothorax or cardiac tamponade. Hypovolemic shock. This is the most common type of shock in pediatric patients, usually due to gastroenteritis, dehydration, or hemorrhage. You have reduced intravascular volume. Preload is decreased, contractility is normal or increased, and afterload increased. Using our ABCDE approach, breathing is usually characterized by quiet tachypnea. Circulation shows tachycardia with an adequate systolic blood pressure but a narrow pulse pressure. Because of the high SVR, extremities are cold, capillary refill is delayed, and peripheral pulses are weak or absent. As shock progress, child become hypotensive and central pulse also become weak. Distributive shock is characterized by profoundly reduced systemic vascular resistance, leading to a maldistribution of blood volume and flow. This category includes septic, anaphylactic, and neurogenic shock. Because SVR is low, the diastolic blood pressure drops, resulting in a widened pulse pressure. This causes increased blood flow to the skin, producing warm shock, characterized by warm extremities, bounding peripheral pulses, and flash capillary refill. However, perfusion to the gut and kidneys remains inadequate. As distributive shock progresses, especially in sepsis, concomitant hypovolemia or myocardial dysfunction can occur, eventually leading to a drop in cardiac output and transitioning the patient into cold shock. Breathing is usually characterized by quiet tachypnea or with increased work of breathing if lung is involved. Circulation shows tachycardia usually except in neurogenic shock. BP maintained with wide pulse pressure, warm extremities, flash CFT and bounding peripheral pulses in the early stage. And as shock progress, hypotensive with weak pulses and cold peripheries. Look for fever, petechial or urticarial rashes, or any focus of infection requiring drainage during examining the child. Septic shock is the most common form of distributive shock and is characterized by decreased preload, variable cardiac output and afterload. The infectious organism activates the immune system, stimulating the release of inflammatory mediators like cytokines. This causes massive vasodilation, damage to the endothelium resulting in capillary leak, impaired cardiac contractility and activation of coagulation cascade. In early stages, signs can be subtle. Your SCVO2 may be normal, increased, or decreased, making serum lactate a highly useful marker of inadequate oxygen delivery. Keep in mind that children with sepsis may develop adrenal insufficiency. Next is anaphylactic shock. It is an acute, multi-system response to an antigen like a medication, food, or venom. It is characterized by severe venodilation, arterial vasodilation, and massive capillary permeability occurring within seconds to minutes of exposure. Under airway and breathing, you will often see angioedema, swelling of the face, lips, and tongue, along with respiratory distress, stridor, or wheezing. Exposure will typically reveal urticaria or hives. Neurogenic shock, or spinal shock, typically results from a cervical or upper thoracic injury above T6. This disrupts the sympathetic nervous system, causing a sudden loss of sympathetic signals to the smooth muscles in vessel walls, resulting in uncontrolled vasodilation. Preload and afterload are decreased. Crucially, unlike other forms of shock, the heart rate is often normal or bradycardic, not tachycardic. You will see hypotension with a wide pulse pressure and, frequently, hypothermia. Cardiogenic shock is a primary pump failure, leading to a profound decrease in cardiac output. This causes end diastolic volume to increase, leading to congestion within the pulmonary and systemic venous systems, resulting in pulmonary edema and increased work of breathing. There will be marked tachycardia and high SVR, causing increased left ventricular afterload. Preload is variable, but contractility is markedly decreased and afterload increased. The body's normal compensatory mechanism of increasing SVR is actually detrimental here, as it increases the afterload the weak heart must pump against. All children with severe or sustained shock eventually progress to cardiogenic shock. Clinically, you will see marked tachycardia and respiratory distress with increased effort due to pulmonary edema. Narrow pulse pressure and cold extremities. Circulatory signs of congestive heart failure will be present, including hepatomegaly, jugular venous distension, basal creps and potentially a gallop rhythm. Obstructive shock is caused by conditions that physically impair blood flow by limiting venous return or limiting the pumping of the heart. It include pericardial tamponade, tension pneumothorax, ductal-dependent congenital heart defects and massive pulmonary embolism. The onset is usually acute, preload variable, contractility normal and afterload increased. In cardiac tamponade, fluid or blood accumulates in the pericardial space, impeding systemic venous return, which in turn result in low cardiac output. You will look for muffled heart sounds, distended neck veins, and pulsus paradoxus, a drop in systolic BP of more than 10 mm of mercury during inspiration. In a tension pneumothorax, air accumulates in the pleural space under pressure, shifting the mediastinum and compressing the great vessels. Suspect this in a trauma patient or an intubated child who suddenly deteriorates. Key signs include tracheal deviation, hyperresonance on the affected side, and diminished or absent breath sounds on the affected side. Obstructive shock in neonates is often due to ductal-dependent lesions, like critical coarctation of the aorta or hypoplastic left heart syndrome. These present in the first days to weeks of life as the ductus arteriosus closes. Look for a higher preductal versus postductal blood pressure or oxygen saturation gradient, and absent or weak femoral pulses. Lastly, massive pulmonary embolism, though rare in children, causes a total or partial obstruction of the pulmonary artery, leading to right heart failure and severe hypoxemia. Risk factors include immobility, central venous catheters, and hypercoagulable states. On examination will show features of poor perfusion. To summarize, keeping this hemodynamic matrix in mind is essential for accurate diagnosis and targeted treatment. For example, Knowing that hypovolemic shock has a decreased preload and increased afterload dictates aggressive fluid resuscitation, whereas cardiogenic shock, with its decreased contractility and high afterload, requires a very different approach focusing on inotropes and afterload reduction. By systematically assessing the ABCDEs and understanding these physiological profiles, you can rapidly identify and treat pediatric shock before irreversible damage occurs. If you found this video helpful for your clinical practice or medical studies, please hit the like button and share it with your colleagues. Thanks for watching.